Hi everybody, welcome back to my channel. If you're coming again, if you're new here, welcome in. I'm Stacy and I like to talk about my hospice nursing and my years in long-term care and my nursing journey in general. If you like what you see, I ask that you like, subscribe, and follow, and let's talk about it. So a lot of times I get asked about morphine. I work in hospice, and one of the common questions and concerns in dealing with families and even nurses that are not as familiar with hospice is the use of morphine. In fact, it's a common concern in facilities as well. Many nurses are hesitant to use it. Many families are hesitant to administer it when we're talking about end of life. Well, I prepared a list here so that I could remember every talking point. I don't want to get chaotic like usual and go off script. So I thought I would look at my notes occasionally and make sure I'm staying on track with it. So one of the things that people think, it's a common misconception, is that morphine makes people die faster. This is a really big fear that families have, and it's also something that nurses who are inexperienced or even sometimes older nurses will think, I'm not giving that morphine because it's going to make somebody die faster. But the truth is, it doesn't hasten death. It doesn't make it happen faster. And when it's used correctly, the doses that we use of morphine are anywhere from 5 milligrams to 20 milligrams. And a lot of times I've seen that 5 milligrams every 3 hours get a person through. So a common dosage that we use is 0.25 milliliters, which equals 5 milligrams in a concentrate of morphine. And what it does is it relieves the pain and it can help with shortness of breath. And so it actually helps the patient relax. So untreated pain and distress can actually cause the patient more. It can cause them more physical stress and exhaustion. See, I had to look at what I wrote here. So it can cause your patient to be more physically stressed and exhausted and restless, to have that pain and to be struggling to breathe. We've all seen people in our nursing career at end of life where they are working to breathe, and that morphine can help lower that effort down and make them comfortable. And oftentimes I have seen people have a little rally while they're taking the morphine and have some good days. And I've also seen people who are using the morphine when they're not exactly right at end of life and they're in their dying process and they need a dose of morphine for shortness of breath. And it doesn't change what's happening in their process and actually makes them more comfortable. Sometimes they're able to eat then when they've had a decreased respiratory effort. Another one, will morphine make my loved one stop breathing? At hospice, our morphine doses are monitored and ordered by a doctor, and they're generally, like I said, pretty low doses, and they're pretty safe. If you think about what people are taking for pain management, not in a hospice setting, I guarantee you that what we're giving in hospice doesn't even equal what a person might be using if they have chronic back pain, for example. So the team carefully calculates, the team being the doctor, calculates the dosage for comfort. And we're not looking to overdose anybody. We're not looking to sedate people. We want them to have the most effective dose that they need to be comfortable, and the least amount to achieve that if possible. So if it's used properly, morphine does not stop the breathing, but it makes the breathing easier. So it doesn't make it harder. It doesn't make them have trouble breathing. Again, if you are giving someone too much morphine and you're not following the correct dosing, obviously morphine is a respiratory depressant. It will slow the respirations, that's the goal. But our goal is not to give them an excessive dose. So when we think about morphine, it is 5 milligrams that we're generally starting at, and it is a really low dose. And the liquid morphine that we utilize is usually getting in the system within 15 to 30 minutes, and a lot of times not lasting beyond 2 hours, depending on how a person is processing those medications, of course. And those morphines are designed to give as needed. In that situation, we use it for breakthrough pain, we use it for shortness of breath. One of the things that's great about morphine is it's been around a long time. There's many different forms. We can use extended release, we can use quick acting, and we can use the liquid. So it can be used to manage long-term chronic pain. We can give long-acting doses. We can give doses for breakthrough pain that happens in between the 12-hour or 8-hour doses. It's really a trusted medication and it's been around a long time. Why is it used instead of other pain meds? I kind of went over that. You know, morphine's effective, reliable, and fast acting. It can be given in liquid under the tongue, and that's helpful when somebody can't swallow. A lot of times people get to a point at end of life where they're not able to swallow their medications, and the medications that we give in hospice are designed to not need to be swallowed. So they do absorb under the tongue and give the person pretty quick relief. And that's one of the good things about morphine, because when you're at end of life and you're at home, you're not getting an IV. You're generally using oral pain relief. And that's not to say that we've never used a pain pump or something like that in hospice, but generally people are getting those oral morphines. We're not giving injections. That's one of the misconceptions that I've heard. We are actually giving oral morphine. And again, it treats shortness of breath and pain, and that makes it very valuable in hospice care and end of life in general. So, you know, in a facility or in home hospice. Will my loved one become addicted? At end of life, we're not thinking of addiction in the last days of life. We're thinking of comfort and managing symptoms. And, you know, it's not really a concern. And again, comfort is the priority. It's important to know the difference between addiction, which is a harmful craving, dependence, or the body adjusting to a medication, and tolerance, needing higher doses over time. In hospice, we focus on easing suffering. We focus on comfort. That is our focus in hospice. Another question, why is the dose so small, or why does it keep increasing? Morphine is highly individualized. That's something that I just talked about, is that the doctor titrates the dose to the patient's need. When you have a person with COPD who is experiencing shortness of breath, as we all know, that oxygen is not going to manage that. The oxygen isn't going to help that respiratory effort. That's where that morphine is going to come in. And you have people who have chronic pain that have been taking pain medications, and now they're not able to swallow those pills anymore. So those medications are going to be adjusted by the doctor to factor all of those things in. You know, the right dose is the one that makes the patient comfortable. It eases the symptoms without causing too much sedation. I have said that in the beginning. I say that again, over and over again. Our goal is not to make a person unresponsive. Our goal is to give them the most comfort possible with the least dose possible. And some patients do need a higher dose to achieve that comfort level. Does morphine knock people out? This is redundant, but the goal is comfort, not unconsciousness. And some people sleep more once their pain or shortness of breath is controlled, because, you know, when you're in a lot of pain, you're tense, you're tight, you've been fighting. You think about the people who have been in pain or short of breath. They're not sleeping well, they're restless, they're not comfortable, and absolutely they're going to sleep while they're adjusting to the medication a little bit more, and probably because they haven't been getting rest for days sometimes. And so again, they're probably exhausted from the discomfort. So hospice teams are very careful about medication management, and that is 100% true. It is a team discussion with our IDT team, and that includes our other case managers, our doctor, our managers, and sometimes it includes our CNAs, also our social workers, our chaplain. We're all discussing the patient, but the doctor is very aware of what the patient needs. The nurse is communicating with the doctor. And so, you know, morphine can safely be combined with other comfort medicines and anxiety medicines and anti-nausea medicines when prescribed correctly. That was one of the questions that I skipped over. Can morphine be given with other medicines? So we do often use a cocktail of medications when we're at end of life. You know, we commonly use lorazepam or alprazolam or, you know, some sort of benzodiazepine, unless a person cannot take those. We sometimes use haloperidol for agitation or anxiety or, you know, nausea and vomiting. That's something that you don't consider, but I have learned a lot working in hospice from my palliative hospice doctors and nurse practitioners. I have only been doing hospice for 4 years. I have been giving these medications in long-term care for a long time, because long-term care, we see a lot of hospice and we work hand in hand with hospice in a long-term care setting. So coming to the other side of it, It has been very valuable to speak to palliative and hospice doctors. There was a really amazing doctor when I worked at another company, and he was very good about educating about different opiates and why they worked in different disease processes and why they didn't work in other disease processes. So he was very vigilant in giving the correct medication for the correct disease process. Morphine is not the only thing we use. Some patients cannot use morphine, and that's another consideration, but morphine is generally considered pretty safe. And the dosages that we're combining together obviously can cause some increased sedation, but they are pretty widely tested and have been used over many years together. And so it's very rare that you're going to see some crazy side effect. Some people cannot take benzos. Some people cannot take, morphine. Some people have to use Dilaudid. Some people cannot take Dilaudid. Some people have to use, there's different types of opiates that can be used, but commonly morphine is it. And the word morphine seems to carry a connotation of negativity with it when you start introducing it into your educational topics with families. It's very frightening, because a lot of people have the idea that once you start the morphine, the patient's going to die. But the fact is that once the patient is in an active process of dying, that's when we're bringing the morphine on most commonly. So I think they go hand in hand. It's not really that the morphine is causing the death, it's just that the morphine is being introduced at the time when the patient is at their end of life journey. And so there is an association with it. I remember, when I was young as a nurse in my 20s, older nurses would say, let the morphine take them. The morphine didn't take them. And I think I had that misconception myself when I was a baby nurse. And when I was up in my 30s, I started working at a facility where we had a nurse practitioner in-house, very hospice-minded, very palliative-minded, very comfort-minded. And a lot of nurses were withholding the medication, the morphine, because they didn't want to kill the patient. That's how they felt. And it really was a low dose. It was the 5 milligrams every 2 hours as needed. But it got to a point where the patient was uncomfortable and they really did need that dose every 2 hours, and nurses would withhold it. We do have guidelines for withholding medications, such as morphine. And a lot of times we are just using it PRN. And I will often tell families and other nurses when I'm training, if a patient is not awake and they're not, don't wake them to take the morphine, obviously. If they're on long-acting morphine, you obviously need to give those doses at a regular interval so that they are getting the dosage that they need to manage their pain. But as far as like end of life, it's really symptom driven. And I remember this nurse practitioner telling me, Stacy, you are not killing the patient by giving them morphine. They are dying. And if you don't give them morphine, they are going to die in pain. They are going to die gasping for air because you're withholding the medication that is managing that symptom. And it really made me think, and I did a little research, but it was very helpful for her to say that to me, because so many nurses that were older than me and had been here longer had said the morphine is going to kill them. And again, when a person is at end of life, that is when we're bringing that morphine in to manage those symptoms. So they do go hand in hand, but the morphine isn't causing the death. It's not making it faster. I've seen people on morphine every 2 hours, every hour for 2 weeks. And I've seen people on morphine every hour for 1 day, for 5-6 hours. So it's really dependent upon the disease process and what's happening with the patient. But morphine, if a person is not allergic to it, is a really safe option to use to manage those symptoms. And I think that people should do their research, and I think as nurses that we have a responsibility to give good education about using morphine, because we all have our own little ideas about hospice, death and dying, and use of opiates. So I wonder, what were some experiences you've had with using comfort medications? Or are you hesitant to give morphine? How do you feel about giving morphine? Have you had families that refuse to allow you to give the morphine at end of life? I'd love to hear about it in the comments. And if you like what you see here, like, subscribe, and follow, please. And I look forward to seeing you soon. Thank you for watching.